I think this sets the stage for our next two questions. And this is, there's clearly a diversity of personal and professional goals out there in the world of clinical practice. And on one end of the spectrum, there's the desire to make money and avoid punishment. And on the other end of the spectrum, there's the idea to lead, inspire, and teach and contribute to new knowledge. And there's a gradient across this. As we consider this, and this is just my personal feeling, but it sets the stage a little bit for this next discussion of registries and clinical trials, is that we won't know if we're relieving suffering or improving lives unless we collect data, a before and an after, in which patient and over what period of time. And so it's truly necessary at this phase of the game to be collecting data if you care about just this basic question of quality of, is what we're doing being effective? If our next question is to how do we take these tools and optimize them, or to figure out who not to use them in, or to improve care and to learn and to teach the future, now we need a higher level of granularity and systematized processing. So this question you could answer in an individual practice by just asking your patients before and after and tracking the data, and how you're doing. But if we want to know why people are doing what and what type of patient is improving and not improving, now there's a need for registries. And there's a number of groups that are trying to work on building the opportunity to collect and contribute to registries. And then, of course, there are going to be settings where we need clinical trials, not just clinical trials of can we detect a difference, but is it different enough? And how does that difference compare to another alternative? So comparative effectiveness trials. If you did a knee replacement instead of doing an injection, what does it look like 5 years later? And so with that lead in, let me go to the slide of our next question. And Scott, I think you were going to lead this one.
Sure. Well, I think that's a nice intro, George. And the question simply is, what is the most effective way to compare these alternative treatment options that we have? Is it prospective randomized trials? Do we use registries? Clearly, RCTs, randomized controlled trials, are the gold standard, but are challenging. They're challenging to do sometimes ethically. They're challenging from a cost standpoint, logistically, organizationally. Frankly, many patients that come to centers for these treatments aren't willing to be randomized. So what other approaches might we have? Can we use registries? Nicolas, maybe you can speak to registries, since Cleveland Clinic has certainly a robust infrastructure for data collection and registries. I know. What are your thoughts on this? And what's the best way to move forward to evaluate these different therapies?
Well, this is an extremely interesting aspect of the field that we currently live in. I think that the first thing is a randomized controlled trial remain the level 1 level of evidence, right? So it remains the gold standard. The challenge, as you well pointed out, the external validity and the application of the findings of an RCT, sometimes it's limited, because when you look at how a randomized controlled trial gets designed, even if it's a pragmatic design, you do have inclusion and exclusion criteria. So you have a determined population for which you are measuring a difference between 2 or more treatments. So that opens the door for what other designs do we have available. And I think that in the past decade, we've seen a raise on the use of prospective cohorts. Orthopaedic has been, and when I say prospective cohort, I mean similar to a Framingham study design, where you prospectively follow up patients and then you look at the risk factors for failure or for treatment efficacy. And in that arena, registries, they play a big role. I think we've came a long way in registries around implants. I would say that those are, even though they're extremely complex, they're much easier than a registry on orthobiologics. The reason is that when we are looking at the arena that we're discussing here, we have the challenges of the registry for the clinical data, but we also have the challenges of how we do the biorepository and the measurement of the treatment that we are actually delivering with all the heterogeneity that you have. If I have to say moving forward, our take from the clinic and from many of the partners, and with Scott, and we've been working on this as well together, we do need to come together, define standards on how to measure and how to quantify the treatment that we're delivering. And we need to also standardize how we measure the outcomes, and we have categorized the state of disease and the time points and the outcomes to follow up those patients in the future. Linking the biorepository with the clinical cohort data in the form of a registry is probably the ball forward, and that's going to actually be able, it's going to be able to give us data that we can probably apply clinically much more straightforward than if we were to do a lot of prospective RCTs, that they would be also extremely expensive and probably not as fruitful as if we were to do the latter approach.
Good, thank you. Yeah. Iain, how about from your perspective from the UK as far as feasibility of clinical randomized trials versus a registry approach?
I think the slide that George put up there was really helpful, because it shows that we have to accept that there are a range of people who are across the spectrum of how much they're willing or at present are able to contribute to research. And that's why I think the registries are essential, because we can encourage those that might not necessarily otherwise to provide their data, and that can provide it. So I think there's essentially a role for both. And the other big point I think that we should make is the value of registries that's specific for biologics is the heterogeneity that we have. Because when we're designing these randomized controlled trials, we really need to be quite specific and refined about the treatments that we're using. But we know that all of these treatments are hugely heterogeneous, and only through big data sources that we can only generate if anyone contributes to these registries might we pick up the subtle differences. So I think there's a role for both, much like there has been a role for both in arthroplasty, and particularly so because of the heterogeneity. I guess that raises a big challenge that we'll perhaps discuss later, which is the heterogeneity is so vast that what variables do we look at?
Right. And we'll come to that exactly. That's such a critically important point. What are the markers of, again, quality, purity, whatever it is, potency, activity, which will probably be different for different tissues, obviously. Like there's a question here about mentioning now, that you kind of brought up this point here, and the one size fits all approach, of course, doesn't make sense. So the question in the chat here about that, and certainly that's been one of the difficulties in this field. We use the same PRP or the same cell formulation for widely disparate pathologies and tissues, which of course makes no sense. Ultimately, we need a much more of a precision medicine approach, if you will, where we can match or tailor the therapy to the patient. So this does relate to this question about registry. So the point is, we need to define the phenotype of our patients. So who are we treating? And on their hand, we need to define what we're putting in the patient. We need both sides. We need to know, what are we putting in the patient? What are the patient characteristics, and how do we ultimately match the two? That's one of our big challenges in our clinical research. Our basic laboratory research has to continue to inform us as to so we can help identify what are those sentinel markers that are practical and reasonable to measure in a clinical trial, whether it's a trial or even a registry. Chris,
sorry, I was just going to make one last point on that, on the trials point there is, if we take PRP, for example, there's over 25 prospective randomized controlled trials, the majority of which are showing benefit for PRP, and yet many of the bodies that are analyzing this data are suggesting that the quality is limited. So I think perhaps the point I'd like to make is it's not more trials that we need, it's really high quality, well-designed ones.
Yes, for sure. See that, you can probably see that for most areas of orthopedics, for sure. Chris, what is the environment in Seoul and South Korea as far as carrying out randomized trials?
Before that, I think that right now the high quality randomized clinical trials are not that necessary, because I think the conduction of randomized control trial for this kind of stem cells and cell therapy would not be too late after we get confident with more easier studies. The higher the evidence, that's of course the good, but the higher the level of evidence, it's more difficult to get the evidence. So we have to make much more physicians to participate in the kind of in any kind of studies. So right now, I think the core study, of course, with proper terminology and reporting prerequisites with minimal but essential, are very important. So that with those good quality core studies with adequate prerequisites are important in advance rather than randomized control trial. So first of all, I think that. And about the registry is we are last year the Korea implemented a new law, Act for Advanced Cell Therapy, Advanced Biopharmaceutical, and it's now implemented this year. And I myself and my hospital are preparing to applying that that law. So now it's a kind of obligatory to make registry. It's based on the national and government-based registry, and I think that would be helpful for the patients and for doctors and for clinicians. So if you are in Korea, it's quite a weak point of our society to make our own registry, own robust registry. I think it's not that good in Korea. So right now, the government makes this kind of new therapy registry is obligatory. So that'll be helpful for both.
Thank you. Scott Bruder, what does the FDA want to see?
Well, they want to see what they call real world evidence, right? Real world. So two approaches. One is prospective randomized trials that use an established endpoint that's a composite of pain and function. Okay, and we're talking about here's management of OA. So pain and function. But they also have expressed a willingness to evaluate real world evidence. My experience in my discussion with them sounds like real world evidence still means randomized controlled trials, but they may not be performed under an FDA IND. It could, for example, be performed outside of the US and still real world evidence.
I think real world evidence, I would think more of a registry approach. That's capturing all comers. That's the real world. Randomized trials can be artificial environments.
It is, but it's hard to sometimes control in the wide net capture, right? Because there are other comments in here, and your own comment around patient definition and precision medicine. These are challenges, but my experiences and the way we talk to the agency is they're looking for randomized controlled trials. And by the way, in the setting of biologics, they want 2 randomized controlled trials, 2 large randomized controlled trials, different than devices typically that only require a single randomized trial.
Okay, 2 per agent, per drug or formulation.
Correct.
Okay. That makes sense. Well, that kind of leads into our next question. George, let's go ahead with your next slide.
Yeah, and just as we finish that, I mean, we're talking about real world evidence, and real world evidence is supposed to inform real world decisions, and the real world decision we're making in many of these patients, the 55-year-old who comes in with 2 varus knees and is working on controlling their weight and doesn't have heart, lung, or liver, kidney disease, that at some time in their life they're going to need an arthroplasty. The real world decision is, are we going to spend time trying to do after therapy, after anti-inflammatory drugs aren't work, are we going to spend time using biologics to try to push that can down further down the road? So the choice is not to do one biologic over the other necessarily. The choice is what's the comparison between those 2 tracks of just committing to an arthroplasty or taking time to see if an injection therapy works. So that's not a randomized trial. That's unless you can induce people to engage in that kind of randomized trial. That requires a different strategy to capture the different courses between those two decisions.